Today's going to be a solo episode. I'm not going to have another guest on. It's me, myself, and I. If you're disappointed, it only hurts my feelings a little bit, no big deal. But today's topic is something that I've been mulling over for quite a minute. It's something that I feel like needs to be addressed. Again, and that's kind of why I'm gearing towards getting people to talk about it and discussions, because maybe it's just me. Maybe I'm in left field and I don't know what I'm talking about. That's fine. That's why I want to bring it up. But I think it's funny how a lot of healthcare providers in general, not just EMS or fire or police officers, but it's also in the ER, in the hospital setting, whatever it may be, but you hear the phrase, I hate people. And I think that's a little strong. I'll at times say, like, I don't really like people, but it's funny because, like, our entire job focuses on being around and helping people. But I'm not saying I haven't said it myself. But on the bigger aspect, we we can't help but sometimes, because of how we were raised or our own morals and values, whatever it may be, we can get into the psychological aspects of what makes us who we are and things like that. But we have our own views and opinions on certain people and how the actions of other people affect the rest of us. And, you know, we'll dive into that in a second. But, it's not just how the patient perceives us, but it's also how we perceive our patients. And I saw a social media post where somebody had posted about that and how we should not use our own views and perspectives of a situation or a patient in general and allow that to affect patient care. And there were people on one side that were like, you're right. If you have this type of patient, or if you're in this scenario that a patient is involved in, it shouldn't affect your judgment. But on the flip side, there were people who were just blatantly, I I don't know, it got to a point where I was reading some of the comments and I'm like, how are you going to sit there and call yourself a healthcare professional and provider? But I don't know. So that's kind of what I want to dig into today. So when we decide to join EMS, we sign up with the general mindset that our job is to take care of patients. And we in reality, we meet them where they are. We render aid in the immediate need that they have. I'm not going to go on a soapbox of why EMS is required to go on a lift assist or then hand them a remote from across the room or getting them up off the floor with no actual medical necessity, etc. And I'm not going to spend this time to add on a caveat that giving care to a patient should extend to having compassion and doing more than just treatments and physical acts, but also in showing an ounce of humanity through spending time listening to your patient and giving support when it's due. Anyways, but going back to our main topic today, based on the NAEMT site, the oath of an EMS provider is to conserve life, alleviate suffering, promote health, do no harm, and encourage the quality and equal availability of emergency medical care. And at the core of why we do what we do, maybe it was your first day of your EMT class and, they went around asking, like, why do you want to be an EMS? Or why we put on the uniform or the scrubs, why we sacrifice our own needs and personal family aspects and devote time to study and stay in this field. We do this job because we want to help people. It's cheesy. It's cliche. But I mean, that's our job. And yes, it's a paycheck, not a very good one, but that's beside the point. But we get our certification for a reason. We study to take the NREMT or whatever certification program process that you have to go through to pass, but we do it for the reason of helping people. And it's not even prideful to say that, like, it feels good when you perform a life-saving intervention, like on an overdose or a diabetic, or you get that patient back from that cardiac arrest, or you have that heartwarming moment when you alleviate grandma's pain after a possible hip fracture on the way to the ER. And you can perform these treatments and administer aid. And there can even be times when it feels like you've rejuvenated your desire to stay in this field because you're making a difference. But sometimes it's not as easy as just taking care of that patient. Sometimes, even though we're called to a scene, it is hard to disconnect your personal predispositions that we have or take ourselves out of the prejudice that we do have. And we're transported in the middle of a scenario that's not just meeting someone where they are, but it's the bigger picture ordeal that we're called to. And this doesn't have to automatically be what may come to mind, like racial or prejudice things or ageism, sexual orientation of the patient, their occupation or their political affiliation, or the socioeconomic level that the patient's in. It hits deeper than that. So, like, for instance, a couple of scenarios. You run on a call involving a patient, but the patient isn't the woman who was beaten by her husband. It is the husband himself. The patient who is in the act of sexually assaulting a minor, but now they're your patient, not the minor, the person committing the act. Or you're called to an MVA where a drunk driver crashed into another family, but your patient is the drunk driver who's having chest pain or who can't breathe or whatever it may be, or is just in pain in general. Or your patient that's complaining of chest pain, you lift their shirt up only to reveal that they have a swastika tattoo on their chest. Someone who was just arrested for rape is now complaining of back pain. The school shooter who went into the school, they're now the patient. And I mean, you can go as far as the drug dealer who went to cardiac arrest in the same neighborhood that you've run countless overdoses on. And on these calls, I mean, granted, some of those, but it's not always the life or death scenario where you have to decide whether you're going to prevent this individual from dying or not. You may have to just decide, are you going to give pain meds or not? And it's easy to say, like, yeah, totally, it's the patient. You have to treat your patient. But in some of those scenarios, what if you saw the faces of the victims affected by this individual that you're called to treat? And I mean, we can justify our own actions by our emotions and withhold treatment and treating these minor things, but we do have to remember our oath is to do no harm and to help people where they are. Granted, we experience compassion fatigue because our job is to hold an umbrella of giving care, and it gets rained on and flooded on from more people who don't require an emergency service and could easily just drive themselves to the ER or an urgent care clinic. So we hold this umbrella and it gets heavy from the compassion fatigue, but that's not the point. And I'll be quite frank, I've been in the shoes of at least one of those calls, and it doesn't feel good to give Zofran because that patient is throwing up. And it doesn't feel good to see that patient lay back on the stretcher with relief from the pain, all the while, like, I knew the act that they committed would affect those victim or victims for the rest of their lives. But we are not the patient. And we're not the one who has to feel the guilt or go to prison or deal with these consequences for the rest of our life. That's their responsibility and the consequences due to their own actions. And yes, what they may or may not have done shouldn't affect our judgment and clinical decision-making capabilities. But when you're in this scenario, it's different. However, we are the professionals. We're the person that, no matter who it is or what happened, it is expected of us to render aid. And at the core of this, Granted, we don't always have the quote unquote full story of what happened or maybe didn't happen. We're not the officer writing the report. We're not the prosecutor. We don't have the camera footage. We weren't in the moment or space when that event happened, whatever it may be. When we get there, we are in the aftermath to take care of whoever it is that is now our patient. And then, kind of on another note of this idea of provider bias and caring for whoever it is, whenever it is, taking out the heavier parts of all this, it is also frustrating to go to the same patient who overdoses, even as far as twice in the same shift. And caveat, if you've never dealt with addiction, it's easy to point a finger at that patient and get frustrated. And I mean, I've seen providers who they lay into the patient with anger and completely lose all rapport that they have with the patient because they've never been in that person's shoes. Granted, it's exhausting, but I'm not saying I'm perfect, but anyways. Or you have the diabetic that you respond to on a weekly basis, and you probably know their social security number by heart because you run on them so many times. And all the while, when you go to that address, it's not by accident that they don't take care of themselves. And just these frequent flyers in general that, I mean, you probably already know it's going to be a thing where you show up, they could be standing outside their house or not, you load them up and you go to the hospital and you know everything that you need to do on the way there. Your report is already written halfway in your mind. Anyways, it's 2 a.m. and you have the person that calls for stomach pain that they've had all day, and then they decide to call. Or you have your calls for psychiatric emergencies of the same patient who bounces from one psych facility to the next. And when you get there, they're already standing outside with all their bags packed. However, at the end of the day, it's our job. And to be blunt and open and honest about it, it sucks. But it's what we're called to do. Our certification tests don't ask like questions, I mean, outside of an MCI triage scenario, they don't ask questions on what patient to treat, because at the end of the call, it's not our job to judge. It's not our job to handpick who we are and who we're not going to treat, and whether we're going to show them the same amount of compassion from one patient to the next. Because just as much as that person who we've come into contact with due to aspects and scenarios out of their control, like if somebody just got T-boned at an intersection and they're not even at fault, or someone fell and hurt themselves and now they have a broken wrist, whatever the case may be, all of the patients who we feel sympathy for and all the ones we may feel a certain type of way about, they all deserve the same level of treatment and care that we provide. So where do we draw the line on the treatment and care, both in interventions and compassion, that we give to our patients? If we give subpar treatment to any patient, no matter the situation or how we feel towards them, it only shows that we are a subpar provider. We don't get to choose our patients, but we get to choose how to act and how to treat them. So if you start a 16 gauge IV on a drug patient or the rude patient, are we gaining anything? Do they really need a 16? If we withhold pain medications because we think they're just being dramatic or they're just drug seeking, is there a trophy that the ER is going to give us because we figured out the great mystery? And on the flip side of being able to disconnect, sometimes it's hard, not because of the call itself or the patient involved, whatever it may be, but it's the aspect of how the call bleeds into our own personal lives, even if we try to prevent our emotions from spilling into the call. And there's calls where you may be dealing with your own personal life, and then you run that call with the exact same thing going on with that patient or whatever it may be. I had a hard time with a call where the patient was a 1-year-old boy in status epilepticus. And the call, it in my abilities of what I could or couldn't do, that's not so much what affected me as it was that it was my nephew's first birthday that day. One medic that I know was fighting with their spouse and ran an MVA where, I mean, the guy died, but it turns out he got into an argument with his wife, and he was going to get some flowers to bring back home. And the last thing that she ever told him was, "You need to leave. I don't want to look at you right now." And I know an EMT who gets torn up after an overdose call because their mom overdosed and died. So it's all these things that, because we have these things going on in our lives, and we go to a shift, and it's people. And like I said, there are these situations that we kind of relate to. Even in that same mindset, there comes to a point in this career and in this field where you have to learn how to turn it off. You just completely turn it off. And not saying that we should be robots and withhold any emotional connection where we can give empathy toward our patient. And I'm not saying to cry all over them because something is sad. I'm 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 not saying that this stuff won't affect us and it won't stay with us. I feel like that's just naive. But I would venture to say that it doesn't get easier as we continue to advance in this field, because maybe it's just me, but it gets a little harder as it all builds. Insert the compassion fatigue. But at that moment, in that time that we have with our patient, going back to what I was talking about, it is not our job to judge. We are the person whose job it is to help and to render aid, whether it's life-saving or it's helping provide physical relief or just being a listening ear to that patient. I don't have an answer on what to do or what not to do. And I'm not saying I'm a perfect provider and I always treat patients with the kindest heart and a warm smile. I just know that if I have a patient to treat, I have a report to write, which means based on my actions and those actions I withhold and I don't do, I'm liable and I'll be held up to a standard of what's expected of me. We're not just the healthcare provider, but we're also professionals. We represent not just our own self, but as soon as we step into that uniform, we're representing the entire profession, not just when it's easy or convenient. So I don't have all the answers, but I do know that I don't want to live with guilt in this job because of my own thoughts and opinions that I place on someone because I'm not in their shoes. I don't want to look back at a call and, like I've done a couple of times, look back at the call and think like, man, I was being a butthole to that patient because I was tired, or I was being a butthole to that patient because I thought something of them way too early into the call, and then I couldn't take it back. Like I said, we're not going to be perfect. We're not always going to have a smile as soon as we walk in the door, and it's hard to it's hard not to dish it back to the patient when they're being rude or the family's being ridiculous and things like that. I'm not saying that. I'm just saying if we are more conscientious about it and we take our own opinions and self out of the scenario and understand that this is someone that just we need to treat. And it's not just putting a chest seal on or a needle decompression, but it's also, I mean, just giving an ounce of compassion where people deserve it. Why not? But that's just me. If anyone has any thoughts, opinions, anything like that, I'd love to hear it. Again, like I said, I don't know everything. I just know you attract more flies with honey than with vinegar, as my mama always says. So, anyways, with all of that, go ahead leave a comment, send me a DM, whatever you got to do. This is all just my thoughts and opinions, and I wanted to throw them out there, kind of get some discussion going. And as I end every episode, so with that.
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.